Thank you for joining us today. We will be discussing core principles of recovery-oriented treatment for individuals with co-occurring mental health and substance abuse conditions. Our presenters are Dr. Ken Minkoff. Dr. Minkoff is the Senior System Consultant at Zia Partners, Incorporated, and the Clinical Assistant Professor of Psychiatry, Harvard Medical School. Dr. Kim Musser, who is the Executive Director of the Center for Psychiatric Rehabilitation at Boston University, and myself, Melody Reefer. I'm a Senior Program Manager at Advocates for Human Potential. We will be facilitating the discussion. The learning objectives for this module are 1. Identifying and apply recovery-oriented best practice principles of integrated treatment for individuals with co-occurring conditions to psychopharmacologic practice as well as to other practice settings. And 2. Define and describe specific intervention strategies associated with each of the principles, including application in psychopharmacologic practice.
Thank you, Melody. This is Dr. Ken Minkoff, and the purpose of this webinar is to create a context for how both psychopharmacologic prescribers and other people offering clinical care and help and support to individuals with co-occurring mental health and substance conditions can organize the way that they work with those individuals in order to provide interventions that are likely to produce the best overall outcomes over time. The starting place for this discussion is to create a context that helps anyone to position themselves about how to be helpful to these folks. And we call this the complexity challenge. Individuals with co-occurring mental health and substance use conditions and other complex needs are people who are likely to have the poorest outcomes in multiple domains throughout our service delivery system. People with any combination of mental health condition and substance use condition, including trauma, including gambling, including nicotine dependence, are folks who are likely to be present in all settings, are people who are likely as well to have issues in other domains, health issues, legal issues, housing issues, parenting issues, cognitive issues, and so on. They have poorer outcomes than people with fewer issues in almost every domain. They're more likely to relapse and be rehospitalized, be more likely to be engaged in other systems, be more likely to cost a lot of money in the system, and most tragically are people who have the highest likelihood of dying prematurely. In the framework that we would like to apply to approaching these individuals, it would be clear that the people who are having the greatest challenges should be the folks who are clearly prioritized at every level for system attention. Unfortunately, people with both mental health and substance use issues are often experienced as misfits at every level, at the system level, at the program design level, and at the level of competency and training of people providing care, including people who provide psychopharmacology. So one of the starting places for how we think about these individuals is to think about how important it is to identify the people who are having the poorest outcomes as the people we most want to welcome as a priority for care, including in psychopharmacologic practice. In addition to the importance of welcoming people into care, it is also important to recognize the importance of inspiring people with hope. When people come to us and they have many challenges, and we may feel as prescribers or other professionals that they don't fit what we know, then we may start to feel hopeless, and that hopelessness may inadvertently get transmitted to the people we're serving. So we want to emphasize that in starting any kind of encounter with people with co-occurring conditions, we want to start by recognizing the importance of inspiring people with hope on purpose and thinking that every person, especially those who may have the greatest numbers of challenges, are inspired when they meet us with hope for achieving a happy, hopeful, productive, and meaningful life. Is this your vision? And if so, how would you get there? So the good news is that over many years, there's been an accumulation of research about how to be successful in working with individuals who have co-occurring conditions. And this has led to the development of some basic principles of success that are associated with specific intervention strategies that can be applied in any population, in any program, including by people who prescribe. And I'm going to go ahead and review these quickly right now, but it's important for you to know that in other parts of this webinar series, we will be going into more depth and detail about the application of these principles inside the psychopharmacologic relationship and other relationships in order that you can think about how to do this in the real world. And we are going to be using a particular story, the story of Nick M., as a way of illustrating that application. So here's the first principle. As I said earlier, complexity is an expectation. And we want to incorporate that expectation in a welcoming manner into everything we do. So the first aspect of this is, as we will discuss in the part of the series on welcoming and engagement, is that it's important when people like Nick M. show up in our office that we make a special effort to welcome them exactly as they are and to let them know that from a customer service perspective, that someone who presents to us with both mental health and substance use issues is in the right place, that we're glad they're here. And we look forward to the opportunity of working with them as a partner to help them with all of their issues, to help them in the direction of having a happy, hopeful, and successful life. In addition, we want to welcome people as they are by removing access barriers that make it hard to be welcome. And this includes paying attention to rules that often have been in place for a long, long time, whether in our program setting or in our practice setting, that say we're unable to welcome people until they have certain lengths of sobriety or other arbitrary criteria that impede our ability to develop the relationship as soon as we meet somebody. And we want to get very good at welcoming the opportunity for people to share what's going on with them, so that if somebody has the courage to tell us that they're using substances, we want to thank them for being able to share that and letting them know that their openness and honesty helps us work with them to help them produce a better result for themselves in moving forward with their lives. What are we welcoming people into? We're welcoming people into a relationship. And successful psychopharmacology, as well as successful anything in helping people to be successful in their lives, is based on developing partnerships. We do things with people as prescribers, not to them. And this relates to what we call shared decision-making. But the relationship is deeper than that. The relationship is empathic, hopeful, integrated, and strength-based. And we work with people in small steps over time to help them address all of their issues to achieve their goals. The best research on long-term results for people with serious mental health conditions and substance use issues who maybe when we meet them are not terribly interested in the things that we might think are important, like medication and sobriety, indicate that if we work well with people, we're going to help about half of them to get sober in 3 to 4 years. And the rest are going to be making significant progress. This is not surprising, but we often get impatient, wanting people to make progress more quickly, and this leads to frustration and difficulty in continuing our work. The next principle is to recognize that all people with complex issues are not the same. Unfortunately, we all have a terrible tendency to lump people and want to have answers that fit into a box, whether the box is based on diagnosis or based on what do we do for people with co-occurring conditions, as if they're all the same. The next important strategy in working with people within this relational context is to simply get to know what their issues actually are. Are their mental health issues more severe or less severe? Do they have issues that last over time, or are they transient? Do they have more severe substance use issues that are more in the range of out-of-control substance dependence or addiction? Or are they making poor choices with their substance use, but more or less on purpose and in control in relationship to using substances in a way that may be harmful, given that they might have a severe psychiatric disorder? And when we're prescribing, we're thinking, if this person has a mental health condition that requires medication, we want to start by thinking, what is the best mental health medication for that condition, for this person? If they have a substance use issue, what is the best set of interventions, including the possibility of medication, for their substance issue? And then we may think about what interactions there might be between those recommendations, but we start by thinking about how to apply the best set of interventions for each issue, including medical issues or housing issues or legal issues, as well as mental health and substance issues, and help that person make the next best small step forward at the same time. So the next principle is that as we're working with people on their issues, we may discover that what is very common is that most people are not in the same place for all of their issues at the same time. And this leads us to a concept that is familiar to most of you. It's called stages of change. And what we've come to realize is that that stage of change is not person-specific, it's issue-specific. That is, the people we work with, just like most of us, may have multiple issues, but in any moment in time, they're going to be in different stages of change for each one. Further, we've learned that interventions and outcomes need to be what we call stage matched. And here's a quick look at the stages of change, which we'll not go through in great detail here, just to show that they are present and relate to what we're doing. These will, as I said before, be discussed in more depth in another one of the webinars in this series. I'm now going to turn the discussion over to Dr. Kim User, who's going to talk about the importance within these principles of collaborating with natural supports to help the person make progress. Dr. Muser?
Thanks, Ken. I'd like to spend a few minutes really elaborating on a couple of the principles that Ken has done such a nice introduction to, and in particular, the principles of partnership as well as parallel processes are of critical importance here. Ken has already talked about the importance of partnership when it comes to partnering with different service providers. And what I'm going to do here is to elaborate a little bit on partnership with natural supports of a person who has a co-occurring disorder. We know that people live in a social context. They experience mental illnesses and substance use disorders in a social context as well. And often the pathway to recovery involves taking their social contexts into account and tapping the social resources that exist within those contexts. Unfortunately, historically, the mental health and substance use communities have often not been as vigorous in reaching out and connecting with natural supports as is possible. And so collaboration with natural supports is really an important facet of effective integrated treatment for people with co-occurring disorders. In order to do this, it's important to begin first exploring the supports that a person has with people in their community. Now, by natural supports, what we're talking about are people who have close, non-professional relationships with people. The most typical individuals would include family members and partners, but also boyfriends and girlfriends or just close friends. And then other people who have a caring relationship with an individual, such as a member of one's church or some other close personal affiliation, can all be people who are natural supports and who may serve invaluably to help a person work in terms of making progress towards goals and the ultimate goal of recovery from co-occurring disorders. Now, in order to engage natural supports, you have to always, of course, begin with the individual consumer, the person with the co-occurring disorders himself or herself, and to explore what the connections the person has with their natural supports, such as family members or friends. Connections including regular contacts, in person or on the phone, persons who the individual feels close to, people who provide some degree of support, and then to explore the nature of the relationship with the person, as well as the potential advantages as well as disadvantages of engaging that person in helping the person begin to recover from their co-occurring disorders. It's very helpful to normalize the fact that all complex conditions involve multiple different players in helping a person towards recovery, and that recovery from co-occurring disorders is no different than recovery from a wide range of other medical conditions, in which the involvement of natural supports is an expected and a useful way of helping the person make progress in terms of managing both conditions. Now, once natural supports have been identified, it's important for treatment providers to do outreach to engage those supports in treatment. Often supports are involved in helping a person access and get into treatment in the first place, but many times they're not, especially if people come into treatment via the criminal justice system, sometimes via involuntary hospitalizations, things like that. In any case, it's critical for treatment providers to reach out to individuals who are natural supports and to reach out in a spirit of helpfulness and desire to help the person work towards their recovery. Now, family members, as broadly defined, or natural supports, can play a wide range of different roles in helping a person make progress towards recovery. They're often critical in identifying needs as well as goals that an individual may have, because typically natural supports know the individual with co-occurring disorders better than anybody else does, certainly better than the treatment providers in most cases. Natural supports can be critical in terms of service planning and encouraging a person to adhere to treatment recommendations, such as pharmacological recommendations, or participation in self-help groups, or therapeutic groups focused on relapse prevention or similar kinds of problems. It's also important that service providers have a friendly and a positive attitude towards the role of family members and other natural supports in supporting an individual from recovery from co-occurring disorders. We sometimes refer to these attitudes and these agency specifications as family-friendly, meaning that they're open to families, they recognize the role of natural supports in helping people recover from co-occurring disorders, they provide comfortable environments for family members with educational information around, such as brochures and so on, that they're understanding and empathic that the clinicians are understanding and empathic of the difficulties that family members and other close people often have in helping a person cope with co-occurring disorders. And that they have flexible hours in which services can be provided so that natural supports can access those services, which often may include evening hours. Natural supports are critical in terms of helping people make progress towards recovery goals, but it's important that those natural supports be recognized as having a caring and positive role in somebody's recovery. Therefore, a critical feature of natural supports is that they reflect a partnership between not just the consumer and the natural supports, but between the treatment team and the natural support persons as well. And such true partnerships or collaboration needs to be non-blaming in its essence, recognizing that there's a shared goal among everybody in terms of recovery from the co-occurring disorders. Other features of services provided to natural supports include psychoeducation. Psychoeducation refers to the provision of information about the nature of the co-occurring disorders and the principles of its treatment, provided in an interactive sort of way that enables natural supports to relate the information to their own observations and to contribute their own observations, many of which may be useful to treatment providers as well. Often, services for natural supports, which include the consumer at pretty much all levels whenever possible, may also include strategies for reducing stress and for improving communication and problem solving, as we know that helping a person with a co-occurring disorder can be a stress for everyone involved, and bolstering the skills for managing stress and effective communication can decrease the effects of stress on everybody and improve the course of the co-occurring disorder. It's also important to recognize that the goals of effective treatment include the strengthening of close bonds, including the bonds of natural family members and other supportive persons. We know that when people lose the support of family members and other natural supports, that often housing instability follows, and people tend to do worse. There's ample research that shows for people with co-occurring disorders, maintaining natural supports and having ongoing contact with people who really care about the person is associated with a fast remission of the substance use disorder and with improved ability to manage the psychiatric disorder as well. So it's important to look at the goals of strengthening bonds within the natural supports as an important overall goal of co-occurring disorders.
Melody is going to wrap up with a comment from the perspective of a person with lived experience.
Yes, thank you, Drs. Musser and Minkoff. Your comments and presentation of sensitive and contextual framework for core principles of recovery from co-occurring disorders is quite meaningful. As a person with the lived experience of recovery, some of the key points that rang true for me and that were quite frankly reassuring to hear and my kind of framework for this, my reframe for this, is hope being the first thing that's prescribed to an individual that comes in for services. That generally people seek services at the point of crisis or chaos in their lives, and being met with the idea that a hopeful outcome can be achieved is an essential ingredient for helping people move forward. The emphasis on relationships and the importance that we combat and help people combat loneliness and isolation, as these are huge triggers for relapse, and incorporating that into active treatment and realizing that a person doesn't recover in a bubble, and that their individualized services are important, that the person's social context, their cultural context, the road that got them to the front door of services is as important as the road that helps them move beyond services. Recovery is an expectation as much as complex issues are an expectation. If we shoot for anything less than an outcome of recovery, of wellness, of resiliency, then we're doing a disservice to the individual. And so looking at natural supports, looking at the core principles of recovery, and certainly examining the stages of change for each condition or issue helps us achieve the expectation of recovery and builds the foundation for hope to exist. Thank you for joining us today. We will be looking at the module titled Integrated Recovery-Oriented Strengths-Based Assessment with Individuals with Co-Occurring Health and Substance Use Conditions. Our presenters are Dr. Ken Minkoff. Dr. Minkoff is the Senior System Consultant at Zia Partners Incorporated and the Clinical Assistant Professor of Psychiatry, Harvard Medical School. Dr. Wayne Centrone, who is the Senior Health Advisor at Center for Social Innovation and the Executive Director of Health Bridges International. My name is Melody Reefer, and I am a Senior Program Manager at Advocates for Human Potential. We will be facilitating today's discussion. The learning objectives for today's module include, number 1, understand how to perform an integrated, recovery-oriented, and strengths-based assessment in psychopharmacologic practice and other settings in order to identify interventions aligned with person-centered goals. And number 2, learn how to use learn how to use information about periods of success to make diagnostic and treatment recommendations for people with co-occurring mental health and substance abuse conditions. I will now turn the module over to Dr. Minkoff.
Thank you very much, Melody. As Melody said, today's focus is on assessment, and this module is part of a larger series addressing psychopharmacologic practice and other opportunities for integrated service delivery to individuals with co-occurring mental health and substance use conditions. As we have pointed out in previous modules, the context for this intervention is that people with co-occurring issues, people with complexity, are an expectation, and therefore all services and interventions need to be designed to welcome, engage, and provide appropriately integrated services, including psychopharmacology, to those individuals. Also, in other modules, we have reviewed a framework for how to do that is based on research-based and recovery-oriented principles of successful intervention. And these same principles are going to be applied in this module to the process of assessment. The purpose of the assessment is to both gather information to identify a diagnosis and establish the best possible interventions, but also to do it in a context where we are focusing on welcoming and engaging an individual with complex needs who may be coming in our door feeling nervous and scared and not necessarily interested in all that we might have to offer. And secondly, to have that same intervention result in inspiring hope for that individual, which in turn is going to make it more likely that he or she will participate in the interventions that we recommend, including but not limited to medication. We call this process an integrated longitudinal strengths-based assessment, or ILSA for short, as a recovery-oriented assessment process that are based on those principles. And the assessment includes, as we go through this, a number of key bullets that are summarized on this slide. Establish welcoming, inspire hope, demonstrate empathy, obtain a chronological story of what is happening with the individual. During this process, we are screening for not only presenting problems, but additional issues, as well as areas of high risk. At the same time, we are looking for periods of strength and success. Within this framework, we're going to be able to do our best job that we can in the first interview to establish a diagnosis as something that we may be appropriately treating with medication, identify where the individual is in his or her stage of change around each of his issues or her issues, and look for those areas in which the individual already has skills and supports, and where those skills and supports may need to be enhanced, also as part of our assessment and intervention. And whatever we're doing, of course, needs to be stage matched to each issue in an integrated framework. So digging into the principles that we've reviewed previously, the first principle is that because complexity is an expectation, we want to welcome people with complexity as a first step in our assessment process. And in another module, we've gone into much more detail on welcoming and engagement. So I'm not going to do that right now, but I'm going to reiterate that the first step in assessing Nick M, for example, is to make sure that he feels welcome and that you are happy to see him, that he's in the right place, and that we make eye contact with him as a person. We engage with him in every way that we can to let him know that we're interested in helping him with all of his issues to make progress in relationship to his goals. The second thing that we want to think about in relationship to welcoming in this principle is that we ourselves as practitioners should not establish barriers to the welcoming process. And one of those barriers is that many of us have been taught what we consider to be rules for creating such barriers for people with co-occurring conditions. I can't do an assessment until I have a certain length of sobriety, for example, is a common rule. And the message here is that those barriers should not be imposed. It is important to begin the assessment with people who have complex needs as quickly as possible. In this particular story, Nick has had a recent hospitalization. He's had a recent period of sobriety, and that's the framework for the way the story is told. But even if he drank yesterday, or if he drank this morning, it would be important for us to do the assessment right now. And perhaps more important, because he might be more at risk. And as you can tell in this vignette, we've prepared a little summary of his story, but it's not uncommon as someone doing an assessment that you have these little summary materials. And often the materials provide a lot of very helpful information to get started. Because the most important aspect of the assessment is not to make determinations based on immediate symptomatology, but to get a really good history, first of all, as a way of making diagnoses, but also as a way of getting to know the person and figuring out how to best engage the person in the process of care. In addition to the importance of looking for historical information and other background, it's important to remember that no matter how a person presents, we have the opportunity to connect with collaterals. And in another module, we talked about that as well. But in this instance, we have the potential of receiving information from his recent inpatient care, as well as from other people in his life. And if we remember that he's a person who is a priority for attention, who's potentially high risk, this further leverages the need for us to obtain this information as quickly as possible. The third aspect of welcoming is welcoming the opportunity to get to know all of the issues that Nick may present with, a process that we call integrated screening. And I'm going to illustrate further how to do this in a way that's in the flow of the discussion as we move through the slides. Now, one of the things that many people say is, well, I'm not sure that I have time to do this. And part of the message of this module is to say that whether you have a lot of time or a little bit of time to do your assessment, it's important to remember to go through all of these things in sequence. You may not have as much time to do each of them, but nonetheless, in practice, and as speaking as someone who works in public mental health settings with often very little time to do lots of things, this framework is something that is extremely helpful, particularly when you're in time-pressured situations. So empathy is based on listening to the person's story. One of the things I've discovered, and maybe many of you have discovered this as well, it's very hard to get a connection with people solely by trying to focus on their symptoms, as if we're going through a diagnostic checklist without talking to a human being. In order to get a better sense of an assessment, I need to hear how the symptoms fit into the context of the person's life. And that helps, particularly in someone who has significant complexity, to understand how to sort various things out for the purpose of ongoing intervention. So one of the ways, the better ways of doing this is to obtain a story, longitudinal story, in chronological order, because that helps to demonstrate flow and pattern that the person may not be able to otherwise demonstrate. And to begin that story with a focus on recent activity. What's been happening in your life over the past few weeks or months that has led up to your being here today? I often will encourage people, as I might do with Nick, to start with a period of time when things were relatively well. So a few weeks or a few months ago, it seems like you had a period where you were not drinking and seeming to do a little better. And then it seems like things have been pretty up and down lately. Tell me about how that's been going. And when I'm inquiring about the story, I'm often going to ask with not, please don't start with your symptoms. I need to get a better understanding of your life, and then to understand how all of these things fit into your life. Where do you live? Who do you live with, if anyone? How do you spend your time? What do you do all day? And how do you feel like the things you're doing are helping you to work toward the goals that we were just talking about? And then within that context, how do your symptoms fit in? Where does your drinking fit in? Where does your mood symptoms, if any, fit in? What else is going on in your life? How's your health? Do you smoke? Do you have any legal difficulties? What are you doing for money? How's your housing? Do you like it? So I'm getting a context of the story, and I'm walking people through a sequence that starts from a period of recent stability, what I was trained in medical school to talk about as the structured history of presenting illness, up to the present time that they're presenting. Inside the story, if you open yourself up to it, you're going to welcome the opportunity to do an integrated screening simply by identifying all of the issues that are present in Nick's story at the present time. And this naturally integrates the screening and gives you an opportunity not only to make a checklist of issues, but to see how those issues fit together in Nick's life and begin to get an impression of how he views those issues in his life, which is an entry into developing a sense of his stages of change. The final component in the principle is strengths-based, and this is one of the most important things that we're going to be doing, and this is going to come back again when we talk about how to establish diagnoses within this framework. But one of the starting places is, when we're thinking about strengths-based, we often think about strengths as a checklist of nice qualities, and we're not quite sure what to do. So we may say things like nice teeth, friendly smile, plays guitar, and then we go back to focusing on deficits and disorders. But working with people in a strengths-based framework fully is one of the most helpful ways of working with people who have significant challenges. And the way of thinking about it is that the more challenges you have, the more strength it's going to take you to get through any day, even with partial success. So the starting place for the assessment may be it tends to be very helpful, and this is how I approach this when I have people with very complex histories, much more complex than Nick, and I don't have a lot of time. One of the most interesting things for me is not that a person with multiple chronic conditions has periods of time where they don't do well. What's amazing is that there are periods of time where they do well. And I want to know everything I can about how they did that. And then I have a better idea about how I, through medication or anything else, or the team, can help them to do it better. One of the things that's important is the ability to use this approach not only to develop a relationship, but an idea of Nick's current skills and capacities. And as we move through the sequence, we're going to get an idea of what happened that caused him to go backwards. And what was it he didn't have in place, either in his own skill set or in his support system or in his framework, that might have helped him to do better, so that we can meet him where he's at, reestablish what worked well, and then help him do better over time. But in addition, this framework helps us to get a better idea of what his diagnosis is. So I'm going to talk a little bit more about diagnostic determination in a couple of slides from now. But in this slide, you'll see that during a period of success of 30 days or longer, we get a pretty good idea of what someone's mental health situation looks like at baseline. And since 30 days is a somewhat arbitrary window of when a formally defined substance-induced disorder, which is it's defined more by transience, temporariness, than by cause, a substance-induced disorder clears up completely in a short period of time. So if we see during a period of sobriety, because we may not have a similar extended period of sobriety in the beginning as with Nick's case, we should be able to get that history from some period of time in the past, as well as from periods of time before their substance use emerged. And in this particular instance, if we go into detail on a recent period or relatively recent period of sobriety, and we see that he had persistent depressive symptomatology and mood disorder syndrome during that period, it helps us to confirm the diagnosis that we might be looking at by history, or potentially establish a presumptive diagnosis when the history is unclear. Now, moving forward to the next principle, this kind of leads us down the path into this principle. All people with complex issues are not the same. And many of you have heard of something called the four-quadrant model. It's very familiar. It's important not to go into this thinking our job is to stamp a quadrant on Nick's forehead and design services based on that stamp. That's not appropriate. The four-quadrant model simply reminds us in a very simple way that all people with complex issues are not the same. Some have more severe mental health conditions, others less so. Less severe conditions. Some have more severe substance use conditions, others less severe substance conditions. And in fact, what's important is when you feel that you need more information to establish what to do, it's important to feel like the way you're going to get that information is by obtaining more detail from Nick about the exact experience of his symptoms or syndromes, particularly during the periods of time when things were going relatively well, and where things like substance use fit into his life, and asking him about that so that you can get the sense of what this is all about for Nick. So, so again, the way that we develop a sense of what's going on from a mental health perspective, a diagnostic perspective, is to move from the notion that diagnosis is primarily based on symptoms to the idea that diagnosis, as I was taught in medical school, is primarily based on history. In Nick's case, I look at his screening sheet, and he has multiple admissions for depression. He has a history of depression that goes back many years. It seems to be designed in such a way as it flows independently of the fact that he also has a substance use issue. And I'm already thinking that based on his history today, however he looks when I see him, he's likely to have a recurrent major depression. Similarly, his alcohol use disorder, based on his history, indicates that he has had periods of significantly out of control and problematic drinking. And so he has moderate to severe alcohol addiction based on his history. Similarly, although it looks from history that Nick has a recurrent major depression, it's important to distinguish, as I said earlier, recurrent major depression from transient substance-induced depression, which would clear up completely once a period of drinking is stopped. And the history, as I said, helps us to do that by looking at what happens during periods of previous sobriety. It's also important to remember that whether or not Nick has major depression, he also has feelings that may be appropriate to his situation, including feelings that he may describe as, I feel depressed, I feel unhappy. And it's appropriate in Nick's situation that he is unhappy and depressed. His life isn't going all that well. And so as a physician assessing Nick, I want to understand myself and help Nick to understand the difference between mood episodes that we might be treating with medication and normal feelings, quote unquote, that's normal in the sense that they're appropriate to his life situation, for which the interventions are going to be different things to help him to do things to help his life situation improve, like helping him find a job and reestablish a relationship with his children. And all of the interventions for disorders are in that context. So just to quickly review, in this framework, no period of sobriety is needed to establish diagnosis. We do it by history. We use the data from past periods of abstinence or limited use to help establish or reestablish a mental health diagnosis. And substance use disorder diagnosis are, and the level of severity are also identified by history and by looking for not just how much you use around in various substances, but the experience of loss of control in the face of serious harmful consequences. And people can be out of control with or without tolerance and withdrawal. So tolerance and withdrawal can be part of the diagnosis, but are not required to establish an addictive a diagnosis of addiction. Now, as we're moving forward, okay, the principle says that when people have multiple conditions, we have to look at each of them as primary and then think about how do we obtain information in the assessment not only to establish a diagnosis, but to establish treatment recommendations. And in Nick's case, we're thinking specifically about psychopharmacology. What do we need to know to help us determine whether to prescribe medication for a mood disorder, whether or not, and what medications to prescribe? And then secondly, whether or not to prescribe medication for a substance use disorder and what medications to prescribe. So within that, the severity and history are critical pieces of information, no less so than if he only had one disorder. And one of the things we want to find out, also by looking at the periods of strength and success, or what are your previous experiences of treatment with antidepressants? Did they work? Did they not? What did you like? What not? What side effects did you have? Were they unpleasant to be avoided? And these are going to help us with future recommendations because whatever we might decide is the best medicine is going to do Nick no good if he can't tolerate it and won't take it. Similarly, we're much more likely to be thinking about medication-assisted treatment for substance use issues for people with more severe substance use issues, compared, as Nick is, compared to someone who may be drinking inappropriately, given that they have a mental illness, but not in a way that's out of control or characteristic of more severe addiction. The next principle is to remember that as one of the things that's important for us to assess is not only what Nick's issues are and what we might like to recommend, but what Nick thinks that he's working on. And we call that assessing stage of change for each issue. And we go into much more detail on this in other modules. So these are the stages. These are some sentences that help you to think about the stages based on how Nick frames what he's doing. Every one of these stages is important in your job and the assessment. Figure out not where you want Nick to be, but where Nick is so that you can meet him where he's at and help him to the next step. And as I said, this is discussed in much greater detail in another module. Now, the final principle is that we want to assess not only what we think Nick should do and what medicines receive, but what skills and capacities and supports does he have? And how do we assess where he needs additional assistance in those areas? So there are two kinds of skills that we're assessing, things that Nick knows how to do on his own to manage his substance use, to manage his moods, as well as to manage other areas of his life, and places where he can go get help, and skills to access those places. So that by the time we're done, hopefully Nick is well engaged in a hopeful process. We have information we can use to identify both psychopharmacologic recommendations and other recommendations that are supported by us as prescribers, likely to be carried out with Nick by other members of the team. But he's leaving with a sense of, we really helped him to feel better as a result of the assessment. We helped him find that he was stronger than he realized, and that there are things that he can actually learn and do that are going to help him do better as he goes along. And even though his course may be rocky and it may take some time, he has a partner in his physician who's going to hang in there with him and help him over time to sort this out. And that would be a wonderful outcome for an assessment. So I'm going to turn it over now to Dr. Centrone, who's going to carry forth in this discussion.
Thanks, Dr. Minkoff. The opportunity here is to think about engaging, working with Nick in a strengths-focused, recovery-oriented way to truly achieve care integration. So this concept that Larry Davidson at Yale University has written quite a bit about, where we're moving away from a pathology-focused approach to assessment and understanding the needs of a client, and we're really focusing on the needs assessment from a strengths-based perspective. The composite of the life that is Nick, the challenges, the opportunities, and the ways that we can partner with Nick to achieve a therapeutic outcome. In the essence of narrative medicine, Sharon and her colleagues at Columbia University really sort of taught us that the story arc is just as critical as the components of the story. So recognizing that inside of Nick is a story. And there's a lot of strengths that we can draw from in our assessment of Nick and really understand the complexity of his life and the opportunities for working with him to find a different place. And Nick is coming to see us because he is essentially seeking something else. Can we help to draw that out? Can we work with Nick to find a new place for him to function and to really develop greater self-advocacy skills? So the first in rather complex approach to working with Nick in what we'll call a strengths-based approach would be to recognize that Nick has had strengths that he has called forward. In the immigrant experience is complexity. There is nothing simple about immigrating from your country of origin to a new environment and assimilating culturally, assimilating socially, finding your way in the world, if you will. And here Nick has created a new life at a very young age, 18 years old, as he describes to you in the initial history, to come to the United States to seek further education. That's a strength we can call forward. And we can say, Nick, in that movement, you've demonstrated a lot of skills. You've demonstrated self-advocacy. You've shown that you have a goal-driven purpose in your life to find further education. How can we use that to actually help you find even more success in your life? Recognizing that in some instances, immigration is a movement away from, not a movement toward. So we have to be willing to walk into the complexity of Nick's life as it relates to his immigration experience. The other is we can call forward the fact that Nick is a father, and he tells you that he loves his children and loves spending time with his children. This demonstrates a real commitment to his family. And can we call forward that commitment in self-advocacy, in working toward his own health and wellness? We know that Nick describes his church community as seminal to his support. Can we work within that church community to find even greater function, to actually anchor him to change? Can we ask him to find natural supports in his community? Can we encourage him to work within those and help to draw that out in our assessment process? Nick has said to you on the initial history that he has a real strong interest in work, and what you learned in your history of present illness and pertinent medical information is that at one point he stopped going to outpatient appointments because he was really engaged in trying to find work. Call forward that as a strength and say, Nick, you know, you've demonstrated self-advocacy in trying to find work. How can we help you to demonstrate self-advocacy in finding the wellness that you deserve and helping to address your mental health conditions and helping to really understand the complexity of substance use disorder in your life and really creating a holistic health plan? We can also really drive at the fact that Nick has engaged healthcare. He's previously been on psychotropic medication. He stopped taking the medication because, as he self-described, the side effects were untenable. So how do we work with Nick to really call forward the fact that he has engaged health? He has demonstrated a commitment to finding resources that can help him seek and source help in his life. And maybe there are other medications that can be used. Maybe the medication that he used previously wasn't the right medication for his needs, and maybe we can, working with psychiatric specialists, find the right fit of medication and life intervention. And then lastly, Nick has come to the appointment, and right there alone in the disposition planning from his discharge at the hospital demonstrates a great deal of strength. Can we use that as an opportunity to really draw him into a further relationship, recognizing that it's complex and that there are many challenges to Nick's life, but the first step of engagement has already been demonstrated. A strengths-based approach is really a focus on the person. And in a seminal article that Barbara Starfield at Johns Hopkins wrote, the person-focused approach to care is really basing our understanding of the needs of the person on the accumulated history that we have and the accumulated history that they have. Moving away from the idea that who the person is very much different than what we might understand in the confines of our medical encounter. And in fact, that medical encounter is just one part of who they are. So what's different about a patient-centered and person-focused approach and what really calls forward a strength-based way of working with and assessing the needs of a patient is it saying that there's a totality of your life. And what I'm engaging with here in this medical encounter in the clinic right now is just one part. How do you help me to understand the complexity and the totality of you? One of the things that I was taught in medical school is to ask the patient, what does you want? Where do you want to be in a year, 5 years? And then how do I help you get there? If the goal is, then we need to align the steps to, and from that we draw from the strengths. So supporting Nick is really about understanding the totality and understanding his history, understanding the social context that he lives in, understanding the many cultural variances that go into our lives. Starting with strengths, recognizing that he has demonstrated strength in his previous treatment and his engagement in seeking services and help. Understanding that his first step to be there in the office with you has already established a commitment. Recognizing that we as providers, as clinicians, are really about assuring a relationship and integrating the role of that relationship into the therapeutic alliance. Look, people don't necessarily care about how much we know. As much as we are committed to the delivery of evidence-based, person-centered care, they first have to know that we care about them as people. And that's a key component to this strength-based world of care delivery. So the take-home to working with Nick is that there are some core concepts, and those core concepts are drawn from the rich literature. That yes, we as clinicians must be grounded in evidence, and that we must be delivering care that is efficacious and focuses on the needs of the individual. But there are some tools that we can use to do that. An adjuvant in our therapeutic alignment includes focusing on strengths, understanding that culture is different for everyone, recognizing that trauma is pervasive in the lives of many of them, drawing forward the motivation that it is people's own commitment to change, focusing on the person and really recognizing that they're more than a disease or a diagnosis. Drawing forward recovery as a process and being engaged in a relationship. The notion of recovery is grounded in health, home, purpose, and community. And we as clinicians, in the assessment of the needs of our patient, should never forget that these things, interrelated, dependent on the context of person's lives and the challenges that they face, are the greatest tools we have to fully understand how to help them find a new life. So Dr. Minkoff, thank you very much. I'm going to turn it over to Melody now. I appreciate having this opportunity to talk with you this morning.
Drs. Minkoff and Centrone, thank you so much for your sensitive and well thought out presentation on integrating strengths-based assessment into our practice. I must say that as a person in recovery, I can think back and easily recall the tension and the fear at points when I would be in an assessment with a professional. One doesn't typically show up at that door when things are going great. There's crisis, there's intense emotion, there's a fear of unknowing, frequently shame. I can easily picture Nick being in that place as well. And to know that assessment can be done in a way that is life-affirming and hopeful, and that combats the shame and the fear that comes with entering into treatment is really revolutionary. And if we can, as a profession, make that known so that people who need services can hear the message, excuse me, that they're going to be welcomed and respected from the very beginning, that their emotions won't be equated with symptoms, that their strengths will be utilized to help them gain mastery of their own lives. It's really quite exciting to think about. So thank you for the messages that you both conveyed in your presentations. Thank you for joining us today. We will be discussing strategies for psychopharmacology with individuals with co-occurring mental health and substance use conditions. Our presenters are Dr. Ken Minkoff, who is the Senior System Consultant at Zia Partners Incorporated and the Clinical Assistant Professor of Psychiatry at Harvard Medical School. Dr. Curly Bonds, who is the Medical Director of the D.D. Hirsch Mental Health Services, and myself, Melody Reefer. I'm a Senior Program Manager at Advocates for Human Potential. We will be facilitating the discussion. The learning objectives for this webinar are: number 1, identify and apply strategies for recovery-oriented prescribing psychiatric medication for people with co-occurring mental and substance abuse disorders. And number 2, identifying approaches for using medication-assisted treatment, also known as MAT, for substance abuse disorders in the context of psychopharmacological practice that supports recovery for people with co-occurring disorders. I'm now going to hand over the webinar to Dr. Ken Minkoff.
Thank you, Melody. This webinar is part of a series of webinars that outlines a comprehensive approach to intervention with people with co-occurring mental health and substance use conditions, including psychopharmacology. And I want to quickly review the principles of recovery-oriented treatment and that we discussed in another module, and then begin to illustrate how these principles are applied to psychopharmacologic practice, and then specifically to the story of Nick M., which you've all had an opportunity to review. So the first principle is that in psychopharmacologic practice, people with co-occurring mental health and substance use issues are an expectation. And we want to welcome those people exactly as they are, remove any barriers to access, to engaging them in psychopharmacology, and be very good at having an integrated approach to screening where we welcome the opportunity for people to share with us what's happening with both their mental health issues and their substance issues, even if we're only prescribing for their mental health issues. So in Nick M's case, we want to be specifically welcoming to Nick as someone who we would let him know that he's in the right place, and we're very happy to see him and work with him as someone who has both mental health and substance use issues. Even though he's been using recently and has just come to us with substance use in his recent past, we're going to welcome him for evaluation exactly as he is. And we're going to provide an opportunity inside the psychopharmacologic relationship for him to talk to us about both his mental health and substance issues at the same time. The second principle is that we're going to start by recognizing that our foundation is to engage him in a relationship. So we're not going to solve the problem in the first visit and come up with a perfect solution. The most important thing is that we work with Nick in a relationship. We're going to be strengths-based. And one of the things that that means is looking specifically not at what Nick is not doing, but looking at all the amazing things that he is doing for each and every one of his issues, so that we can partner with him around what he does that works. When does the medicine helpful? How does he take it successfully? Where does it become a struggle? What can we do to help him to do it better? Where does managing his symptoms become successful? Where does he have a hard time? How do we partner with him to figure out strategies for helping him with that, given that the medication is unlikely to be perfect? How do we do the same approach, looking at times when he's successful in not using substances, and how we partner with him to help him do better? We look at the specifics of what his issues are. We don't treat Nick as someone with co-occurring disorder as if all people were the same. In addition, we have to think about our approach to prescribing as each issue is primary. And as we'll see a little bit later, that means how we think about what interventions to use, both medication interventions and other interventions, is based on what is the best intervention for each of his primary conditions. In Nick's case, major depression and alcoholism or alcohol addiction. Further, we have to match what we're doing to where Nick is in his stage of change for each issue. This will be covered in more detail in another module in this series, but as we're working with Nick, he may be in an active stage of change for getting help for depression, but maybe only in contemplation or thinking about or talking about what to do about his drinking, but not committed to abstinence. In this particular story, it appears that Nick is, for the moment, in an active stage of change, wanting to stabilize both his depression and his drinking, and we'll approach it that way. But in the module on stage-matched interventions, we'll talk about other possibilities and how you might approach those. And finally, as we're working with Nick, we're working not just to hand him prescriptions as prescribers, but we're helping him as partners to develop the skills that he needs to be successful. How does he take the medicine successfully? How does he talk to us as a prescriber partner openly and honestly? How do we help with other skills, both self-management skills, asking for help skills, working with his family members, his church, his other natural supports, to help him through the difficult times that he will have addressing his life issues finding a job, managing his mood symptoms, addressing his substance use, and so on. So first important basic message is the importance of promoting access and continuity. So in Nick's case, it is important that we welcome him as he is, and we let him know that we're going to begin working with him right now. Secondly, we would approach this as he has at least two serious disorders that he needs help with, and he's asking for that help. So one of those is major depression. How do we figure out the best approach for major depression for Nick and with Nick to help him take his next step of progress and be engaged with us in not only a shared decision-making process, but a continuing shared decision-making process to figure out what's going to be most helpful for him over time while we're attending to other parts of his life. At the same point, we're going to be looking at his alcohol use issue. And he clearly is further along the path to alcohol dependence, alcohol addiction, as opposed to alcohol misuse or what we used to call abuse. And that will influence our psychopharmacologic strategies, as Dr. Bonds will be talking about a little bit later on. And the final bullet on this slide is very important. For any person with a known or presumed serious psychiatric disorder, it's important that we initiate or continue the use of the best non-addictive medication strategy for that disorder, even though they may still be using their substances. And that's going to be important as we work with Nick over time, because he may slip, lapse, relapse, and we need to be working with him to help him figure out how to proceed with the treatment of his major depression as we go. If we discontinue medication for his major depression and disconnect him from treatment because he slips, he's going to go backwards. And that disconnection is more likely to produce poor outcomes for Nick than if we keep him connected to treatment and work with him closely over time. Now, when we're considering the match of psychopharmacology to condition, the first thing on our list is to remember that there is an emerging set of medications specifically available to help people who have addictive disorders. And these include medications like methadone and Suboxone that are opioid maintenance therapy. There are long-standing medications like disulfiram or Antabuse for people with alcohol use disorders. Naltrexone as an opiate blocker, which is approved now for opiate maintenance for addressing people with opioid use disorders. But there are also a whole category of anti-craving agents, including naltrexone and acamprosate for alcohol use disorders, which Dr. Bonds will be talking about later on in this module. In addition, what we're learning is that a number of medications that have been approved for other uses are being investigated and having preliminary results in helping people reduce their use of substances. And these may include some of the anticonvulsant mood stabilizers, as well as a range of other medications, which we do not have time to go into in this particular module, but are described in more detail in a number of the references that are attached to this module, including the principles that have been described by SAMHSA that you'll see at the end, as well as an article, a summary article that I wrote for Psychiatry Times in April of 2013. There's also, as most of you know, the availability of medication like bupropion and particularly varenicline for a nicotine dependence that also function as anti-craving agents. So these all should be in the repertoire, and all prescribers should be thinking about how to incorporate this into routine practice to help people like Nick who have co-occurring issues, who are interested in using all the available tools that they can to help them make progress. Now, for mental health conditions, some of the things that we're learning are that certain medications may have helpfulness in addition to their help for the mental illness. They may also have a positive impact on co-occurring substance use. However, the first important decision guideline for medication for a mental health condition is first, it has to be the right medication for this person. What does that mean? Well, first of all, you're working with the person to help them make a decision about what they want. This is based on their previous experiences, their experiences with side effects, their preferences about dosing strategy, and for some people, their preference about whether or not to take medication at all. So even though we may have something in research that says this would be ideal, it's not ideal if the person doesn't want it and isn't going to take it. And inside the relationship, we work collaboratively to help a continuing experiment with folks so that they can figure out the right strategies for themselves. Now, all of that being said, there are some helpful tips that are good to know. So one of them is that there's been an accumulation of literature that says that clozapine, in addition to being the quote-unquote gold standard medication for a psychotic illness like schizophrenia, also is the only antipsychotic that seems repeatedly to demonstrate helpfulness to people in reducing their substance use. So in the past, where people may have regarded ongoing substance use issues as a contraindication for using clozapine, we're now beginning to shift to think that for some people, shifting to clozapine may help them with both their psychotic illness and help them to reduce their substance use at the same time. We're learning that for people with a variety of unstable mood disorders, ranging from bipolar 1, bipolar 2, atypical mood disorders, that the newer generation of mood stabilizers seems to have an impact not only on those mood disorders, particularly the more atypical ones, but can also help people reduce their substance use as well. Again, these are preliminary findings, isolated studies. It should also be important to remember that for those people who most benefit from lithium, they should continue to receive it, even though lithium has not been demonstrated to have a specific effect on substance use issues. Nonetheless, it's helpful to be aware that the newer generation mood stabilizers can have a dual impact and may be well suited for certain people. In the category of antidepressants, the generally accepted approach is to start people with an SSRI or SNRI because of the safety profile. However, for people like Nick who have major depression, there's one piece of research that indicates that mirtazapine is the one antidepressant that may be both dually helpful in the sense of helping both the depression and helping the alcohol use disorder. Now, does that mean that you must prescribe mirtazapine to Nick? No. Mirtazapine's side effect profile may be very unacceptable to Nick. It's just helpful to know that this is something in your repertoire, but then in your discussions with Nick, you would be working with him to help him figure out what medication strategy is going to be best for him based on what he's tried before, what side effects he likes or doesn't like, and then at the same time helping him realize, you know, what the course of antidepressant treatment is like, and that, as I'll talk about a little bit later, so that he can work with us and not get disappointed when the antidepressant doesn't immediately make him feel, quote unquote, better in the context of this. In addition, there are an array of medications available other than benzodiazepines to help people with anxiety, including alpha-2 adrenergic blockers like clonidine and guanfacine, which have the benefit of helping people reduce some of the adrenergic tone that is associated with trauma. There are assortment of antidepressants that can be used for generalized anxiety disorder. Some of the mood stabilizers that have anti-anxiety effects. Short-term use of atypicals is sometimes useful for people who are having exacerbation of anxiety. And buspirone, which can be very effective, but it's important to remember, particularly for people with significant substance use disorders, that it may take longer to work than in people without and may require higher doses. So you need to work with people over time to help them to be engaged in the process of utilizing this medication. And then for attention deficit hyperactivity disorder, what we've learned is that it's helpful for people with substance use disorders early on to begin with something like atomoxetine. There are other non-stimulants that can be helpful. However, there are people who have ADHD who actually benefit with co-occurring substance use issues, who will, once their substance use disorders are reasonably stable, need to be or best benefit from sustained release stimulants. So it's important in thinking about this always to be working with people over time to find the best ongoing strategy with them for managing their serious mental health condition while working with them to help them figure out how to manage their substance use issues over time. Okay? Now, once we begin to work with people like Nick who are working towards sobriety, and working with them on prescribing medication, and in Nick's case, he's someone who's suffering from a mood disorder, major depression. But in addition to that, Nick also has a very stressful life. He has a lot of reasons to feel unhappy. So when it says distinguish normal feelings, it means that, you know, this is not a situation in which we prescribe an antidepressant and somebody's going to come back 3 days later and say, I feel like I'm happy all the time. So when it's very helpful as we're working with people, and this is particularly true for people who have substance use issues, who may be using substances as a way of coping with quote-unquote normal painful feelings, to understand that the purpose of medication is to address a mental illness. What I'd like to do now is to turn the conversation over to Dr. Bonds, who's going to dig into a little bit more detail on medication-assisted treatment, particularly as applied to someone like Nick who has an alcohol use disorder. Dr. Bonds?
Thank you, Dr. Mensah. As my colleague pointed out, it's important to meet the person where they are when they present for treatment, like Nick, when they have both a substance use disorder, in this case alcohol use, and also a mental health disorder, in this case major depression. The concept of medication-assisted treatment has gained momentum to where now when we as providers encounter someone who has co-occurring illnesses, it's important to think about them both simultaneously and independently, in that you can treat both simultaneously, but you do have to think about what interventions are going to help them the most. For medication-assisted treatment, it basically means that you're going to give something that's a medication to assist with the substance use disorder in the context of a more holistic strategy that's integrated into other treatment efforts. For example, the person's going to continue with psychotherapy and psychosocial rehab, and of course they're going to be engaged in something that's going to encourage them to maintain their sobriety. For alcohol specifically, there are 3 agents that come to the top of the list as being evidence-based to treat the alcohol cravings and disorder. The first that probably most of you are most familiar with is disulfiram or antabuse. This is the oldest and probably most classic agent, but its limitation is that it's an adversive therapy. In fact, its mechanism of action is that it inhibits the enzyme that's responsible for metabolizing acetaldehyde. And acetaldehyde is a compound made by alcohol when it's metabolized, and the result is that if you get high levels of it in the bloodstream, a person becomes pretty ill. The other agents are naltrexone and acamprosate. We're going to talk about these in the context of how you might approach them with the person who's in front of you to present them. Many of them will already, as I said, be familiar with antabuse, and you talk about this as being a drug that if you decide to take it, then you really can't drink while you're taking it because it will make you pretty ill. You'll feel as if you have a very bad hangover. So I would explain that this is something that works best if you take it every day over a long period of time, and it's really not advisable that you drink at all because you will have negative consequences from it. In terms of explaining about naltrexone, I would point out that this agent is available both orally and as an injectable, and adherence to it is a bit easier because it, unlike the antabuse, actually decreases the cravings for alcohol. Naltrexone, of course, was originally produced as a opioid antagonist, and so it has some efficacy in that area, but primarily for alcohol, it reduces the desire to go out and drink. One of the nice things about it is that it's a long-acting agent, and even if someone still continues to drink a bit, they can successfully take naltrexone and reduce their drinking. Last is acamprosate, which is a molecule that affects the chemical balance between some of the neurotransmitters that are driving drinking, and it also can reduce cravings. It binds to GABA receptors, thereby inhibiting their activity or increasing their inhibitory activity, so it reduces the desire to drink. One of the limitations of this drug is that you have to take it 3 times a day. That makes it unique amongst the others. I would have a conversation with Nick about his ability to take a medication that fit with his lifestyle, and for some people, actually, the idea that they have something that they can take repeatedly throughout the day, like at meal times, will increase their motivation because they're familiar with other agents that perhaps they had to take several times a day, like benzodiazepines, and it might be a reminder that I'm doing something healthy for myself. Overall, the conversation about MATs or MATs is that there's a comprehensive approach that's necessary, and in the long run, they increase survival, they increase retention in treatment, and they really prevent people from getting into trouble with the law. In Nick's case, he's had an arrest for disorderly conduct, so I point out some of the benefits of combining medication with other treatments, and he also has a desire to work, and there's evidence that these agents increase employment over the long haul. So since he comes in looking for a source of hope, just point out that these medications are one alternative to assist him. As I go on to the next slide, there's a way that we assess co-occurring disorders that's a little bit different than maybe in the past. I think some people were taught that you wait 6 months of sobriety before you really evaluate as to whether or not someone has a mental health condition. But another alternative is to really look carefully through the chronologic history of the person and look for time frames. In the case of Nick, we know that he's had episodes of depression and episodes of heavy drinking. But we also know that his drinking started very early in life. In fact, he was drinking when he was a teenager. If you refer to the case, you can also see that he's had several times when he would leave a detox program, become severely depressed, and even suicidal. And these were episodes of sobriety during which he developed these depressions. So in his case, the alcoholism and the mental health problem are intricately intertwined. But it is important to tease out perhaps if a person has had a prolonged period of abstinence, did they still have those mood symptoms? And what you'll often discover is that what drove them back to drinking or whatever substance they're using is that their symptoms were just so bad that they couldn't tolerate the symptoms, and they were self-medicating with the substance, in this case, alcohol. So another important point is to look at previous pharmacologic history. In Nick's case, if we think specifically about the depression, he does tell us that he's been treated with antidepressants before, but over time he would drop out of treatment and he would stop the medication, and in this case it was because of side effects. Since we have a vast array of different antidepressants that are beyond the scope of this module to treat depression, an important question would be, what antidepressants have you taken in the past, at what dose, and for how long? Those 3 key questions will help us to avoid maybe something that's had an adequate trial. And keep in mind that traditionally 4 to 6 weeks of treatment at the highest tolerated dose is considered a reasonable trial of an antidepressant. So if he hasn't had that, we can put those back on the list, provided that it wasn't side effects that caused him to stop them. If someone had side effects that were continuous and persistent, it's unlikely that they're going to be willing to try that medication again. Another effective strategy is to look at what symptoms they're having. In Nick's case, he complains of difficulties with energy, also complains of difficulty with concentration. And so we might try to choose an antidepressant that might be more activating or more stimulating as opposed to one that's going to make him feel sleepy or sedated. Dr. Minkoff pointed out that mirtazapine, also known as Remeron, can be helpful in using to reduce alcohol cravings in someone. So that's one that I would consider, but with the limitation that this is a pretty sedating drug. Sometimes I would ask a client in front of me, what's the deal breaker? What side effect can you absolutely not tolerate? And a lot of young men, particularly, you'd ask about sexual functioning. If he has a relationship or plans to have one, that's an important question because we don't want to impair that important part of life. And there is an antidepressant, bupropion, that can come without any sexual side effects and can, of course, be used in other addictions like cigarette smoking to reduce cravings for nicotine. So picking an antidepressant has to be personalized, and it can be done in the concept or in concert with the MAT. The last point to consider is family history. You want to review whether there's anyone else who has the same mental health disorder. If they've taken an antidepressant, that serves two purposes. One is that the person that you're working with may be familiar with it and more willing to take it. And secondly, you might be able to establish a genetic response history. It's likely that if a close relative who's taken a drug had a good response, then our client might have the same good response.
Dr. Bonds and Dr. Minkoff, thank you so much for your sensitive presentation discussing the strategies for psychopharmacology with individuals with co-occurring disorders. As you referenced Nick, I thought about how he, in fact, could be one of my friends. As a person in recovery myself, I feel like I know Nick and the things that are important in his life, like employment and his relationship with his and children and with his church are all things that are paying a price because of his addiction and how depression affects him, and the strategies that you've outlined perhaps offer options for Nick and for me as we explore both the positive outcomes of psychopharmacology and a very measured and sensitive consideration to some of the drawbacks as well. As each of you were speaking, a couple of salient points came to me. I thought about how the importance of maintaining and differentiating symptoms from feelings, and that feelings are something we want to keep, even those that are challenging or painful, because they're part of our humanness, and symptoms can be what we may try to decrease because of their disruptiveness in our life. I thought about the importance of social context and how Nick and other people who are seeking recovery manage their recovery and wellness within the context of the people around them and the messages of society, and how that as providers and as prescribers, consideration to that is equally important. The emphasis on educating Nick about his choices and providing decision support is critically important and sometimes overlooked, but letting Nick know what the possible benefits are and what the possible side effects are so that he can weigh those options and make the best decisions for him. And then finally, well, no, actually not finally, I wanted to mention that the decision support is also important for the care provider, for the doctor or the other prescriber, because their access to ongoing and new information that both of you outlined is so important, that medicine is not static, that prescribing practices are dynamic, and staying attuned to the best practices can result in better recommendations. And then finally, how all of those factors, relationship, feelings, social context, education, decision support, are foundational for shared decision making. Bringing Nick and me and other people in services into the decision-making process, and understanding that we are experts of our lives and we benefit from your expertise as exemplary professionals, makes for a wonderful combination and the pursuit of the best outcomes possible.
Melody, this is Ken. One of the things that I've found for myself that helps with what you're describing is when the person I'm working with has a peer supporter who is allied with both them and with me to help in that collaboration. Is that something that you've observed as well?
Absolutely. There's going to be a module that talks a bit more about peer support, but introducing the topic here I think is very timely. Many times people need the model of self-advocacy, that it's okay to speak up to your doctor and other team members, and peer support is a perfect vehicle for helping people learn that they have an important role in their treatment decisions, and perhaps most importantly, that recovery and wellness and resiliency is possible and is a reasonable goal and outcome for the services that they seek. Individuals who are participating in these modules can find more information on this topic and other topics by following the link on the slide that you have before you. We would also invite you to subscribe to the quarterly Recovery to Practice newsletter, which focuses on timely issues, current thought leaders, and provides tips, resources, and events of potential interest. If you're not receiving the Recovery to Practice newsletter, please sign up at the following email address: rtp@ahpnet.com.